Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, ANITA FINLEY.
Dr. William Leone, who is, he's everything. Well, he's very special to us. Bill Leone made such a difference in our life because Bill Finley is going to be 93 today. I was going to say he's going to be 93. He's 93, and of course he walks, he dances. Yeah, we were dancing the other night. We went somewhere. I went to the Wick Theater, and after the theater, they then do some. They have like a little band from the theater, and he said, "You want to dance?" I said, "Sure." And he was dancing. And that's amazing, isn't it? Without knowing what his body looked like when you got a hold of it.
Well, it's because of his spirit and who he is inside. And
well, true.
But sometimes if your spirit has you dancing, even if your body doesn't want to, you dance. But he has a very good body.
Yeah,
he's remarkable. He's 93. And,
yeah. And he keeps bragging. He said, "I weigh the same as I did when I was in high school, 150." And I said, "Well, okay, Bill," because when I make him dinner, I said, "Don't give me too much." I said, "Okay, Bill."
That's great. He's looking to be, 93, 103.
Yeah, I hope so. I told him I'd kill him if he didn't get to be that.
Okay.
So how about you? You just keep going on and on and on. And what's new in your life?
It's so fun to be able to do something for a living that you're passionate about. And when you're passionate about something and you're focused on it, you just keep having fun with it and seeing new ways to make a change and make it a little bit better and keep polishing it. And it's good. It's wonderful. I look back and, I'm starting my 27th year of just doing one thing and at just one hospital in one part of the world. And so, and I think what's changed the most in a really positive way, despite all the noise, is how much quicker people are getting well and getting back into their lives compared to even 2, 3, 4 years ago. And that's really heartening. That's really super positive.
Tell me why. Not only why you're so you feel so good about it, but tell me why. What have you done that's different?
Well, it's not just me. It's there's always a lot of little changes that isn't just one change. There's so much emphasis and marketing about, let's say this approach or that prosthesis. That's just one little part of it. There's so many other parts. There's our whole change in philosophy in terms of preventing or preempting and then minimizing and how we handle post-operative pain. It's psychological because although pain's very real, it's very individual. Some people are much more disabled with it than others. But if you know intellectually, you have the confidence going into it that everything isn't a surprise, people handle the experience much better. So it's that whole pre-surgical getting educated about what's going to happen and having a plan turns out to be super important.
So you said post, but people are in such pain. That's why they come to you, because they wait and wait and wait, right?
Yeah, but so many people are paralyzed to go forward particularly with what I do, which is a hip or knee replacement, because of their fear of the unknown, that they're going to be in so much pain after the surgery. And believe me, I get it, but it's just such a shame because so many of these individuals, when they ultimately capitulate, and at some point you almost have to, then it's so much harder to get a perfect result. And they're just not doing themselves
talk
a favor.
about that. So you're saying if they wait too long, it's harder to get a good result.
Well, of course. It's like anything. If you try to tackle something when there's less deformity and less soft tissue destruction and less contracture and less disability and less deconditioning, then it's just easier to get to your baseline and beyond it. And it doesn't mean they can't have a great result. It's just harder. So so with our current strategies, if you will, more changing in philosophies about don't need to give everyone just narcotics. That can be a small part of the picture. We can use many different drugs to approach it from different angles. Steroids and more fluids and anti-inflammatories and Tylenols and some neurologic drugs. And And all of a sudden, and doing regionals and doing a cocktail of some local injectables into the areas about the hip or the knee, and then giving them the confidence before they go into surgery that they're going to walk the day of surgery. And they do. They get out of bed and walk the day of surgery. So what it really translates to is when I get to see them the next morning, they've already been out of bed walking. They can get dressed. They can go to the bathroom. It's a whole different mindset. So they want to go home. And it turns out, no surprise, there's nothing like going home. It's not only is it safer, but people just want to be home. We all do. You have a better experience. No one's waking you up to take your blood pressure, and no one's messing with you. And so it's all very empowering. And because we've been doing it so long now, like anything, patients always teach us. And they always, in the beginning, you're very, very hesitant and careful about what you instruct people to do. But with time, of course, they teach you that they're going to do what they're going to do anyway. And before you know it, you've kind of changed what you're telling people because you're seeing so many patients do so well by just very quickly resuming their life, going back to work, driving their cars, swimming in their pools, playing their golf. So when I look back on the experience, it's refreshing. It's how it should be. It's medicine, because that's what medicine is. Always making little incremental changes and looking back and saying, "Wow, we're really better than we were."
I hear a book somehow.
A book.
So I hear a book, but I want to just say that one question I did have: the anesthesia. For years, Bill had every anesthesia, but now you're doing other things, aren't you?
Well,
talk about that. Who should have anesthesia and who shouldn't?
Well, everyone needs anesthesia because certainly it would be torturous. There can't be pain. This is all about people have to be completely comfortable. But of course, the drugs are better if someone has a general anesthesia, which requires typically a tube being put down their throat and then at least very temporarily being paralyzed. The drugs are much short acting and more precise. But at least in orthopedics and what I do, lower extremity orthopedics, the regional or the spinal has really become pretty much the gold standard if it's appropriate. And in the vast majority of patients, it is appropriate. I mean, there are those patients that have certain conditions. They've had so much spine surgery, their back's fused. It's not appropriate. They have such a condition within their heart like aortic stenosis. It's not appropriate. But those are the far and few exceptions. For the vast majority, if you can do something where they don't remember ever having a needle placed in their back, and it's just a little pinprick, and they don't remember it, and their legs go to sleep for 2 or 3 hours, and then they don't wake up suddenly like a general. A general is like a light switch. You have it, you don't have it. And this is a much more gradual waking up, so it's more gentle. And then you combine that with a lot of local injections into the tissue with different medicines, some local anesthetics, Marcaine with epi, an injectable type of anti-inflammatory, a Toradol, maybe some steroids, some morphine. It turns out there are mu receptors locally. There's a new med called Exparel, which actually puts a local anesthetic inside of a complex fat molecule. And so it means it can kind of slowly break down and leach out over the next 24, 36, even 40 hours. So, everything is just, it's all about preempting and letting people know what's coming and giving people the confidence and, of course, doing a good job. We're better at getting the components in the right position. We're better at the components are better. We sometimes, we take a step back. Everyone's trying to do what needs a 5-inch incision through a 2-inch incision. No, you're going to hurt the tissue. You're going to tear it. You're showing off. It's not what you need to do. Or you're not being meticulous with tissue and very gentle and having absolute meticulous, precise hemostasis or no bleeding. So that's another thing we do. We give a medicine now which diminishes the bleeding. It doesn't diminish the bleeding, but it stabilizes the clot. It blocks the destruction of the early clot. It's an antifibrinolytic. It's called tranexamic acid. And, it's been kind of coming out for 4 or 5 or 6 years, and it's absolutely the gold standard now. And so all of a sudden, the incidence of transfusing people is so much less because they're bleeding less, and because our insight in terms of when they need to be transfused is less. And because we've recognized that when we have people give all this blood for themselves before surgery, what it's really doing, of course, is making them anemic before surgery. Well, and then we give them back these living cells, so it's a transplant, even though it may be their own. Potentially it could give them an infection, or the cells aren't as flexible and it's not delivering the oxygen to the tissues. So it takes years, of course, to massage all these really good intentions and these studies and begin to kind of shift out, what's real and what are the important parts of this, and what are that sounded good at the time. But it's wonderful. I love what I do. I'm
you do. This is why I love to have you on. This is Dr. William Leone. He is an orthopedic surgeon, the most elegant, the most, extraordinary physician. I mean, he really is. He is kind. He is sweet. He loves this. He's really been very special. And it's called the Leone Center in Orthopedic Care, and it's over at Holy Cross. But I have to say that Dr. Leone is very careful. That's one thing you know about him. And when he's done our Cure Symposiums before, he actually brings the metal pieces that he puts in you. He explains it, and it makes people have more confidence. And then you have, of course, your own inventions that you've made, but, with your level and to make sure everything's right. But Dr. Leone, you said you've been practicing 26 years.
Yeah.
How many, and you probably know, how many patients have you had? I had to ask you that. I mean, how many thousands of patients?
It's...
You ever counted? Do you have a dartboard up there?
Yeah, people don't believe it, but, before I started this more concierge model, I was, doing 600 and 700 a year, and you add 20 years. And so now it's still, between 400 and 500 a year. So, people of hip or knee replacements. So, you add that, and if you're really enjoying it and paying attention, and everyone's, you're seeing the subtleties and the nuances, it really teaches you, well, certainly not to make the same mistakes and to keep seeing little things you didn't see before. I think one of the most exciting things I'm suddenly doing now, actually, I'm writing a paper on it, and I'm getting ready for a talk on it, and I'm really excited, is that as good an operation as total knee replacement is, and, when we think about those surgeries that have just so changed the quality of life for mankind over the past century, you'd have to say total hips, and you'd have to say cataracts, and exponentially the number of total knees going in almost doubles the total hips now, and you'd have to say total knees. So, but total knees haven't been as consistent as total hips. And while many, many, many patients do extremely well, there's certainly a subpopulation of people that have had their knee done, despite all the best prostheses and the best efforts from their surgeons and the best-looking X-rays and therapy. They're just not happy with it. They're not comfortable. And when we've reached a point now in studying what we do where we're asking more important questions. And the questions are not just, do we think the patient did well? The questions aren't, do their X-rays look good or the angles measure up? Did we do a good job there? The questions aren't, let's look at the interfaces between the components and the bone. Are they stable? These are the questions. Are their range of motion adequate? Is their strength? What's a much more important question is the patient happy? And there's a number of validated patient-reported outcome measures, these very important, standardized tests, if you will, that measure that. And it turns out that our report card is not as good as as for so many years we'd like to pat our backs and think it was when we ask our patients after total knees. And if you look at a whole bunch of studies, just since, 14, 15 studies, just since the turn of the century, since 2000, there's really 20 to 30% of people that if you ask them if their expectations were met and are they satisfied, they'll say no. And that's disheartening. That's different than the total hip. And then if you kind of burr into that subpopulation and start saying, why aren't they happy? And you eliminate loosening, and you eliminate infection, and you eliminate some of the, malpositioning. But then you get into it, you recognize there's a whole subgroup of people which we call the looks good, feels bad group. And they're the ones that are very frustrated because they go from doctor to doctor to doctor, and everyone says, boy, it looks pretty good because your incision looks good and your leg looks straight and there's no redness or swelling, and look, you're walking pretty good, but they're not good. They're not happy. And it turns out that very subtle malpositions, incongruencies, disrotations between the femoral and tibial component can make real changes in the tensions on the surrounding soft tissues. So when one thinks about a knee, everyone thinks it's just a big hinge joint. Well, it kind of, but it's a hinge joint with a pivot. Interesting. So when you flex your knee, it turns out that the tibia internally rotates. Or when you flex your knee, it turns out that the back part of the femur, the posterolateral condyle, falls off the back of the tibia. And then when you extend it, it goes the opposite way. The tibia externally rotates. So there's this screw-home mechanism, and it's pivoting around the inner compartment, the medial compartment. And we've got these cruciates and these tissues that have all evolved to help glide our anatomy, our bony anatomy, through this complex motion arc. And the closer we can reproduce that normal motion, the more comfortable someone is. And the more closely we can create equal pressures or loads in the two compartments, the inner and outer compartment, while it's doing this motion, so the more comfortable and more normal the knee feels. And we get it right about 70 or 80% of the time, meaning we don't get it perfectly right about 20 or 30% of the time. So the question is, how do we get a better handle on now really trying to figure out which part of what we're trying to do went awry?
And what have you come up with?
Well, I've been using for our primary knees, our first-time knee replacement, a very innovative new technology pressure sensor, a kinematic sensor, kinematic meaning movement sensor. It actually comes from Israeli technology, and it's a little micro computer chip with these pressure sensors inside of a trial, meaning it's not the real implant, but it's the implant that you put in that looks like the real piece of plastic. And so once you place the components or the trial components, and then you place this insert with these pressure sensors and this microcomputer chip, then it allows you, it then measures, and you can see on a monitor, you're no longer guessing. You're no longer just feeling it and saying, I'm using my experience. I know what it should feel like. We only get it right 70 or 80% of the time, and we use our eyeballs and we use our experience and we feel it. But if you can actually quantitate it and see the measurements on a monitor and see the motion signature, now you have a blueprint. You have a roadmap, if you will, to address tight structures or change things subtly to optimize the motion signature and the pressure. So again, now taking that technology, which we're using on the primary, and applying it to the group of people that come to me that have had their knee done and they've seen 5 doctors and they're not happy. Well, now I can, like taking your car to the mechanic where it's not working, the gentleman plugs it into a computer, your car, and the computer spits out which system is probably the problem. Well, now I can plug this thing into a knee, and I can provisionally close the front structures, and I can range the knee, And I can say, oh, that's the problem. It's lifting off here, or it's not loading there, or it's too tight, or it's not rotated right. And now, rather than just throw up your hands and say, I'm going to change it all, we're just going to redo the whole thing, which is the normal mentality. Now I can be much more precise with saying, we don't need to change the whole thing. Everything is pretty good. The only real problem is just back here. Let's just release that.
This is fabulous. So this would be your new cutting edge. I have to book you now for next, let's see, it'll be in April.
Well,
book you now because this is exciting stuff. So you're back again with your level. That's why you did the level, because with hips and you figured out your invention.
I'm not one that likes to guess.
No, I was just going to say, as you were talking, I said, I just hear it now. You like to know it. So are you getting a lot of revisions?
Well, yeah, it's always been how I cut my teeth and built my reputation. It just requires a lot more planning and thought and skill. And I've always taken a lot of pride in it. And people are so grateful, because there's not a lot of people that really are willing to take on someone else's work. And but people are people. We're having dinner with my wife, and I were having dinner with a couple the other night, and she's a nurse, and she was going on with how much medicine has changed. And I was kind of thinking, and actually verbalized that, how I love what I do, and it's not really changed at all. I mean, yeah, the computers and all the BS with the insurance companies and what's going to happen with CMS
versus other kinds of things.
But in terms of, people coming to you and sharing with you what's really going on with them and their fears and their concerns, and you meet their families and you take care of them, that part is age-old.
You're a listener. You're a listener, which is wonderful.
Of course.
So, well, of course you say, but a lot of doctors don't. But let me give everyone who's listening here a phone number, because I have to tell you something. There's no one that I would really recommend more. I really have to say this, but Dr. Leone. And so, and I use your name a lot. Sometimes people come and sometimes they have other ideas. Phone number is 954-489-1575. Again, get your pencils out. It's Pencil Talk Radio. It's 954-489-4575. And it's Dr. Leone, Leone. It's the Leone Center for Orthopedic Care. And you can just hear when Dr. Leone speaks. You can hear the passion in his voice, but the care. And so we know that now when someone comes in, you evaluate what it is. And sometimes there are people who are coming back because they're not happy, even though it looks very good, as you said, but then you try to figure out why are they not happy. Because I have a few people I know that, Bill walks and he has no pain and he's fine. And they don't understand that. And they still, it's not good. And I tell them, I said, listen, you ought to go to Dr. Leone and all. But of course, people are very confused. As you know, there are a lot of doctors out there, and they don't have the experience that you've had, and they haven't the creative world. And the other thing is that you really watch over this patient. That's one thing I have to say, that before and after, and you really want to make sure that it's right. It's not, okay, thank you, the surgeon's away, you never see the surgeon again. You know that story.
Yeah, no, that's not my style. I know I'm not. I enjoy my patients. I'm very blessed. I really take care of a lot of really cool, interesting, smart, different people. And, I look at this cross-section of people that I get to interact with. And, it just, as you guys were talking about, Haiti before I walked in, I'm thinking about a wonderful couple I met this week who came over to me from Haiti. So, I see a lot of people from out of the country, and a lot of people that come in from, nothing in the state of Florida. And it's nice.
So let me ask you about how long and what determines how long hips or knees should last. Let's say people don't fall. Is it like, I think Bill said 25 years.
Yeah.
Is that
so?
Tell us how you figure that out.
Right. So it's such an important question, and it's just one we don't have an answer to. Certainly everyone wants to know, if I have my hip or my knee replaced, how long will it last? And I take care of some people in their 20s and 30s. So it's a very important question. And what we do know is that if you look at people who had their hip or knee done 15 or 20 years ago, and they were done with components, with hip or knee prosthetics of that era that all of our studies and experience have demonstrated were the good ones. They got it right. They weren't outliers. They weren't recalls. They were good ones, and they were done, by surgeons, gals or guys, that really did it for a living. They were well done, so that everything just kind of came together. Then, and we look at how they've done. There's about an 85 or 90% chance that they're still functioning very well 15, 20 years later, and they're failing about 1.5% a year. So the question is, what's changed in 15 or 20 years? Our techniques are so much more refined, as you would hope and expect, with the different technologies we use to put them in more precisely, just like you'd hope. And our prosthetics, the actual components that are made, are on a magnitude better in terms of their wear characteristics than they were, from the 15 or 20 year ago era. In terms of, the ultra high molecular weight, highly cross-linked polyethylenes and the interfaces and the ceramic balls and the different. So is it really reasonable if someone's going to just be a normal, really active person, that it can last way more than 20 years? Yeah, it is.
And Dr. Leone, we're going to have you back again because we've just run out of time. So everybody, you want more questions? We could give you more answers. We're going to ask Dr. Leone to come back again. Thank you. It's just, every time you're here, I learn so much, and I have a great sample at home, an example of everything's great. We thank you very much, and we'll talk with you again.
It's always a privilege. Thank you for inviting me.